Thank you. So I will be focusing upon management of HER2 positive MBC. So we had a very great talks previously. Just before we saw a very nice talk which incorporates various points in management of triple negative breast cancer and BRCA mutant breast cancer. So we'll start with the point that approximately 30% of all breast cancer patients become metastatic after diagnosis. If we see that how much amount of patients you see hormone receptor positive and HER2 positive are around 13%, and total it makes around 20% to be HER2 positive. It might be somewhat higher in our setting. This is Western data. In our data, it is somewhat higher. It is close to 25 to 30% actually, if we combine the HER2 FISH positive patients. So that has been our data. So if we see the algorithm, it is now we know that THP protocol, that is either DOSI or PACLI with trastuzumab and pertuzumab is the standard of care first line option in MBC upfront. And the second line option till now it was TDM1, and third line options included TDXD, tucatinib, and various other combination which we keep on using. That includes capecitabine plus trastuzumab or K plus lab, which is very commonly used. And there's also option to use trastuzumab plus lapatinib. So if we see the data for each one of them supporting the recommendation, the Cleopatra trial, this is the actually I find this is the best data for supporting the use of pertuzumab in any setting. But pertuzumab showing so significant OS benefit was not seen in any other subgroup. But this is the group MBC where you can see overall response rates are also increased by 10 to 11%, and main benefit which you see is in the terms of overall survival. Overall survival is increased from 40 months to 56 months. So an absolute improvement in overall survival by 15 months for pertuzumab that has been established by Cleopatra trial. And that is the setting where we want to use pertuzumab in all our patients. The second line therapy, Emilia study, TDM1 versus K plus lab. This we keep on reading from our previous times. We see that there is some benefit, 9.6 versus 6.4 months. So there is some improvement in the PFS around 3 months, and also somewhat better cranial penetration, but not so much encouraging actually. So definitely there is an unmet need, and the problem which remains there is if we shift from first line to second line treatment, around 1/3 of the patients will drop out of the treatment. So I mean to say around 20 to 30% patients will not be able to receive next line of therapy. That makes it very difficult, and it leads to a significant amount of patients not able to receive subsequent lines of treatment. That reduces overall survival very significantly. So if we see the data from trastuzumab, pertuzumab followed by TDM1, the main thing that we need to understand is that Emilia trial and this Cleopatra trial were designed simultaneously and were running simultaneously at the same time point. So in combination, Trasto plus Pertu, that was not very widely used at the time of utilization of TDM1. So in this study, the TDM1 study, we see that the patients who had received previously pertuzumab, they had somewhat significantly lower benefit of utilizing TDM1 in the next line where pertuzumab has already been utilized. And this is a data which you see. This is Italian real world evidence data. If you see 3 months versus 8 months, this is for pertuzumab naive patient, 8 months benefit with TDM1. With pertuzumab export, the benefit is only for 3 months. So that is a clear point that suggests if you utilize pertuzumab, TDM1 is not so good option. That helps us to establish that. And as you see, the PFS rates also drop out significantly from 18 months to 9 months in the second line. Yes, so it's very clear that TDM1 is definitely not so good option when you have utilized pertuzumab, and also it has limited efficacy. So if last 2 years, we have seen a number of drugs getting FDA approval. If you see, Deruxtecan got approved, then neratinib, tucatinib, and margetuximab, these all got US FDA approved. And so it has been done within 1 year span of time. That shows that there is definitely an unmet need, which was realized by the authorizing committees, and they led to approval. Coming to the TDX data and the mechanisms, you see this is a drug somewhat similar to TDM1, but what is the differences? Will come to that. 8:1 antibody drug ratio, you can see that there is a cleavable linker as well, and topoisomerase 1 inhibitor payload is there, and that gets incorporated. If you see into the tumor cell, the TDX, when it enters, the deruxtecan is released into the macrophages, and that leads to apoptosis of the cell. At the same time, this deruxtecan can diffuse to the neighboring tumor cell because this is cell membrane permeable. That leads to a significant bystander effect, which is not present with any other molecule. So to see the differences, 8:1 drug into antibody ratio with TDX, while it is 3.5:1 with TDM1. Tumor selective cleavable linker is present in TDX, and also bystander effect is very well documented, even by the cell line studies and also the mechanisms. So based on all these available initial studies and initial work, open label multi-center phase 3 data, Destiny Best 3, DB03 data came out, and this was a large, well-conducted study of 524 patients, where patients have received trastuzumab and taxanes previously. Patients could have clinically stable treated brain mets, and there should have been 2 weeks or more between the whole brain radiation. That was the only point which was required for brain mets. The patients were randomized to receive 5.4 mg per kg 3 weekly of TDXD versus TDM1, which is the standard dose which we use, 3.6 mg per kg. Both were given 3 weekly with primary endpoint of progression-free survival. If you see, this is one of the studies where we find that Asian patients were in majority than Western patients. You can clearly see around 57% patients in TDXD arm were from Asia. So that gives us much more confidence, because we tend to rely very much more on Western data, but now where we have good Asian data also available with more than half of the patients included from Asia, it gives us very strong confidence. And 25% patients, that is around 1/4 patients, were having brain mets at presentation, and visceral disease was present in 70% of the patients. So that is a point that these were patients with high disease burden, and these were included in the study, and around 2/3, more than 2/3 in fact, had visceral disease. And pertuzumab exposure was also present in 60% patients in both the arms, and ECOG and at least one line of treatment have been received by 50% patients, both the arms. If we see this PFS curve, this reminds us of the osimertinib data, where we found a very wide separation of the curve starting very, very early, and that is sustaining throughout. So that gives, again, a very big confidence in utilizing this treatment in our practice. You can clearly see median PFS not reached in TDXD arm versus 6.8 months in TDM1 data. And if we see the time-bound duration at around 1 year, you can clearly see a significant difference, close to 80% versus around 35%. So a significant big improvement in median PFS can be observed here, with hazard ratio as low as 0.28. A very few therapies have reduced hazard ratio less than 0.5, and this is one of the very strong PFS benefit seen. And when a drug gives so strong benefit, it is understandable that all the subgroups will be getting benefit, and this is very clear with this graph, this forest plot. You can see all the points towards much benefit, close to 0.3, hazard ratio 0.3 in all the subgroups. That is why the overall hazard ratio was much in favor of this TDX arm. Again, this is investigator-initiated assessment of PFS. Endpoint of OS, it is encouraging, but it is yet not reached, but we need to await further data. Patients with or without brain mets both tend to get a good amount of benefit. We all know patients with brain mets will having somewhat lower PFS. If we see TDM1 with brain mets at baseline, it is only 3 months of PFS, and that is 15 months with TDXD. So 5 times PFS in patients with brain mets. That is very, very encouraging. No brain mets at baseline. TDM1 is giving around 7 months of PFS. With TDXD, it has not yet been reached. If we see the 12 months PFS rate, it was 35% versus 75%. So it's quite simple. More than doubling of the 1 year PFS rates median PFS rates are at least 5 times with utilization of TDXD over TDM1, which is presently the best second-line treatment available with us. If we see the exposure adjusted safety summary, which is designed to tell whether how many patients could continue the treatment and how much was the efficacy, it is very clear that there was no difference in drug related deaths during the study, and exposure adjusted rates were also very similar. There are one or two special interests of with TDXD, and ILD or pneumonitis has been much discussed about this drug, because in the early studies it was found to be somewhat significant and there was no clear guidelines for the same. When ESMO published guidelines for utilization of TDXD, how to monitor ILD pneumonitis, it became very easy, and now we can see the rates of ILD and pneumonitis, which are very significant, are very, very low. No grade 4, grade 5 ILD or pneumonitis. That is very hurtsome to know. And LVF decline is also similar, no difference in that compared to TDM1. And also, more than 50 to 60% patients, ILD or pneumonitis will completely resolve with treatment, with time, with proper treatment, appropriate use of steroids, and many patients will be able to continue TDXD. Though if there is grade 3 or more ILD, there will be requirement of dose reduction. If we see the ESMO update, this year's update, the quality of life events are also significantly in favor of TDXD. That means overall health status and quality of life was well maintained. So this conclusion that PFS hazard ratio is 0.28, there's 5 times improvement in the median PFS and consistent benefit across all the subgroups and efficacy endpoints. And OS trend is also encouraging, but let's see and wait for further data. Safety profile, it has been comparable, and we have now understood how to manage ILD and pneumonitis. This needs to be taken care of properly, but there will be no grade 4, grade 5 toxicities if proper care has been taken for the same. So this data clearly support the utilization of TDXD, and it will be available to us commercially also by next year. So hopefully our patients will get the benefit of the same. So coming to the tucatinib data, the HER2 climate study, this came around 2 years back, and this was also a well-conducted study with 2:1 randomization, combination of tucatinib plus trastuzumab plus capecitabine versus trastuzumab capecitabine, and the overall response rates were 23 versus 41%, with median PFS improvement from 5 months to close to 8 months. So yes, there is some benefit, but the quantum of benefit which we just saw from TDX data is not so much. Yes, it can be given. If we see the exploratory overall survival in patients with brain mets, there is some improvement from 12 months versus 18 months, 6 months improvement. When this data from TDXD was not available, it was looking to be great, but now we have much better data with TDX, so that makes this data somewhat smaller. And also in patients with active brain metastasis, if you see the approximate hazard ratio, that is also just below 0.5. That means even in active brain metastasis, this is a good treatment option if available. Coming to the neratinib data, this drug has been available from a long time, but not much frequently used, and that is why not much in our practice. This is the NALA trial, which we have read from the Times over DM exams. Neratinib with combination of capecitabine versus lapatinib plus capecitabine, there is absolute improvement of 2.2 months in PFS. I think that is why this, and the taking amount of the toxicities which it gives, a significant amount of diarrhea, this drug didn't become much famous among the oncologists. Coming to the margetuximab data, yes, this data initially showed some amount of PFS benefit, but that was very small. And the OS update is also showing that this has a significant OS benefit. That is why, though it is an approved option, it is not much favored among the oncologists. So let's come to the guideline recommendations. If we see the ESMO 2021 metastatic breast cancer guidelines, it is very clear that patients with second-line treatment after trastuzumab and pertuzumab, patients without brain mets, trastuzumab deruxtecan is definitely the preferred treatment option. If patient with active brain metastasis, you have the option of tucatinib plus cape trastuzumab or using trastuzumab deruxtecan. So in all patients, there is a good data to suggest the utilization of TDXT, and guidelines also recommend the same. And if we see the data for others setting for a HER2 combination, the trastuzumab deruxtecan is usually the most favored treatment option now in the guidelines. ESMA MCBS score, which we also see, MCBS score is also very strongly in favor of TDXT, coming because of the very significant data and significant benefit. So this has been now included all the guidelines, and the first line treatment with THP protocol is the preferred regimen, and TDXT is the preferred second line treatment in all the NCCN recommendations as well. Third line treatments can utilize TDM1, capecitabine plus trastuzumab, or trastuzumab plus lapatinib, whichever is feasible. So there is now a further buzz about HER2 low metastatic breast cancer. I will just touch upon it. If we see that around 50% patients are actually HER2 negative because they were FISH negative, but HER2 2 plus or HER2 was 1 plus. So this constitutes around a very significant subgroup of the patients, which includes either hormone receptor positive or even triple negative breast cancer. So we know that triple negative breast cancer has very limited treatment options, but if we see HER2 low patients, a significant number of patients, though TNBC or hormone receptor positive, will come into HER2 low subgroup, and that opens a very significant avenue of utilizing a drug which has significant activity and significant bystander effect over the treatment. So in this subgroup also, with HER2 low positivity, the treatment is able to give significant PFS benefit at doubling of the median PFS, 5 months versus close to 10 months. And overall survival is also getting prolonged by around 7 months. So that is significant because significant change in the improvement in both PFS and OS has been seen. And hopefully this will be a norm later, and this drug will be available to our country as well. So take home messages: THP followed by TDM1 was an option, but now with availability of TDXT, this has changed, and TDXT is now the standard recommendation now. And the problem is that median PFS drops very significantly by half after THP and TDM1, while this is not the case with TDXT. And major therapeutic improvements we have seen has occurred, and DB04 data also demonstrates HER2 low breast cancer. It has very significant potential to double the median progression-free survivals and also improvement in the overall survival. So with this, I would like to stop here and thank you. If there are any questions, we can take it. Thank you. Thank you.